Good afternoon, everybody, and welcome again. Thanks for joining us on today's session of the Cardiopulmonary Physiology course. Today, our session will be focused on sepsis, and we have some great speakers that I'm sure we're going to be learning a lot from. Our first speaker of the day is Dr. Shelley Lawrence. Shelley is an associate professor at the University of Utah, and her research interests focus on understanding the fundamental mechanisms of bacterial pathogenesis in the neonatal innate immune system. And she also designs and conducts multi-center clinical studies with the primary goal of translating innovative diagnostics and therapeutics from the bench to the bedside. Thank you so much for joining us today, and I pass the torch towards you.
Thank you. I really appreciate the opportunity to be here this afternoon and talk about the physiology of neonatal sepsis. I just want to start by saying that I have nothing to disclose. So let's begin our discussion by acknowledging that no consensus definition for neonatal sepsis exists, and definitions used to describe pediatric or adult sepsis are not applicable for our unique patient population. In general, sepsis is defined as a potential life-threatening, dysregulated host-inflammatory response to infection, which may lead to organ dysfunction or failure. The inclusion of organ dysfunction or failure is complicated in our patients, as preterm infants, especially those born at the limits of viability, have significantly underdeveloped organ systems that may often present as dysfunction or failure. A preterm infant with RDS, for example, may have respiratory failure requiring intubation and mechanical ventilation. They might also have an evaluation for possible sepsis, but the main etiology of their lung condition is often associated with immaturity and not infection. Therefore, a requirement for organ dysfunction in neonatal patients is really not useful. Historically, though, neonatal sepsis has been described as an ill-defined clinical syndrome accompanied by bacteremia in the first 28 days of life. But the isolation or identification of a bacterial pathogen is not a requirement in Sepsis 3 or the third international consensus definition of sepsis and the septic shock released in 2016, nor is it a component of the current pediatric consensus definition. Moreover, a pathogen may be identified in blood in as little as a third to half of cases of sepsis in adults or pediatric patients, even in the setting of septic shock. So although the gold standard for the diagnosis of neonatal sepsis is bacteremia, between 6 and 16 times more infants will receive antibiotic therapy for blood culture negative conditions in the absence of bacteremia in the first few days of life. Furthermore, blood cultures are routinely negative in certain types of infections, such as meningitis, soft tissue infection, osteomyelitis, pneumonia, and perforated bowel. Therefore, a false assumption exists that life-threatening organ dysfunction, which may be accompanied bacterial infection, must be associated with bacteremia in neonatal patients. The error of this premise was demonstrated by a study of newborns with unequivocal infection documented at autopsy, but in which 14% of cases had negative pre-mortem blood cultures. So which of these babies has neonatal sepsis? Any or all of these kids could have bacteremia, but only 2 of them appear critically ill that could meet the classical definitions of sepsis. And only one, this one in the left upper corner, has a definite identifiable focus of infection. Classical clinical signs and symptoms of neonatal sepsis are presented here. Usually, infants present with temperature instability, increased apnea, bradycardia, or desaturation events, tachycardia, abdominal distension, tachypnea, and increased work of breathing. I would like to note that hypotension is a very late clinical finding in sepsis. Most cases of sepsis, however, the bedside nurse or the parents usually raise the alarm to the clinician by informing them that there is something not right about their baby or that their baby is acting a little differently. Many times, these astute individuals raise the possibility of infection by asking the clinician if they think it could be sepsis. But let's talk about the neonatal response to infection. I'd like to begin by talking about this hematopoiesis slide to remind everybody that the origins of neonatal blood cells during fetal development is different depending on your gestational age. Hematopoiesis, or the development of all blood cells, occurs primarily in the liver and the spleen after the first couple of months of fertilization and remains within these organs until the 7th month of gestation. These primitive cells are phenotypically and functionally different from those found postnatally that are derived primarily from the bone marrow. For example, neutrophils are primarily activated by hypoxic environments, which typically occur in infected tissue. In the womb, however, a very hypoxic environment exists, so these cells must adapt and become tolerant. This tolerance is also important after the baby is born, which is a time when they are immediately introduced to trillions of microbes, which will ultimately become their microbiome. One other example is the neonate's adaptive response, composed primarily of T and B cells. It must also remain silent during gestation to prevent a robust inflammatory response against maternal foreign antigens that may threaten the pregnancy. Therefore, the neonatal immune response is not deficient per se, but evolutionarily designed to maintain the newborn's health and well-being in a hostile environment during its development and following birth. Preterm infants were really not designed to live outside the womb, so their immune system, like all other of their organ systems, must mature quickly to meet the challenges of a different hostile environment or life outside the womb. This illustration shows the primary cells of the immune system, which is divided into innate and adaptive immune responses. The innate immune response is composed of skin, mucous membranes, and secretions that protect the organism from the outside womb. It prevents most infections or eliminates them within hours of an encounter, but it's not specialized to distinguish small differences in foreign molecules. Infants can become colonized with pathogenic bacteria prenatally if the mother has chorioamnionitis, or during birth through passage through the birthing canal, or postnatally by horizontal transmission. These microbes can then travel to the lungs and cause pneumonia or gain access to the bloodstream, where they can disseminate to other organs and tissues. Neutrophils are the first immune cells to arrive at sites of infection and/or inflammation and comprise the majority of white cells. They can be stimulated by pathogen-associated molecular patterns, or PAMPs, which are microbial products such as LPS toxin of gram-negative bacteria, or they can be stimulated by DAMPs, which are intracellular proteins or matter released by dying or damaged host cells. PAMPs and DAMPs then induce pathogen recognition receptors, such as toll-like receptors or nod-like receptors on innate immune cells and endothelial cells, to produce cytokines that elicit an inflammatory response to combat the offending pathogen. These cytokines can stimulate the production of other pro-inflammatory mediators, such as leukotrienes and prostaglandins, that promote neutrophil accumulation at the site of infection. They also promote platelet aggregation, which can initiate thrombocytopenia and/or contribute to disseminated intravascular coagulopathy. Acute phase reactants are also triggered and promote microbial phagocytosis. Acute phase reactants also initiate tissue repair, but this response is not immediate, and we will discuss one, CRP, later in the talk. However, all of these pro-inflammatory mediators can coalesce and initiate a cytokine storm if they are produced in excess of what is needed for the bacterial infection. Alternatively, pathogens can gain access through the intestines due to immaturity of the mucosal barrier, especially in extremely low birth weight infants. Other events that can damage the integrity of the gut barrier include microbial dysbiosis if exposed to antibiotics or pathogenic organisms, hypoxic injury, and even enteral feeds or formula. Once the mucosal barrier is disrupted, microorganisms can transmigrate through the lumen and induce toll-like receptors to promote a pro-inflammatory response, leading to enterocyte apoptosis. Neutrophils are also activated and aggregate and infiltrate into the inflamed tissue. These activated neutrophils produce noxious substances like reactive oxygen species and proteases that can further damage the involved tissue. These events exacerbate the pro-inflammatory response, leading to bacteremia and/or sepsis, with vascular leak, septic shock, and the potential for end organ damage or failure. At the vascular level, a normal steady state exists when the endothelial cells are strongly connected by intracellular junctions, and neutrophils are loosely associated with the endothelial cell but not stimulated. During infection, however, the vascular endothelium is exposed to cytokines, PAMPs, and DAMPs that intensify the upregulation of pro-inflammatory cytokines, triggers neutrophil aggregation, translocation, and net production. The glycolic structure of the endothelial cells is thought to disintegrate. The net formation and platelet aggregation may lead to thrombus formation and initiate mechanisms that trigger disseminated intravascular coagulopathy. The damaged endothelium becomes leaky with third spacing of albumin and water and depletes the intravascular volume, which is enabled by the production of prostaglandin. Leukotrienes enhance the aggravation of polymorphonuclear cells to the source of infection. These cells, that include neutrophils, release proteases and oxidants that further enhance this tissue damage and can cause further injury or organ failure. As noted in the illustration, albumin is a small intravascular protein that can readily escape into the tissue in septic shock and contribute to third spacing and generalized edema. So what happens when the first line of defense fails? You call in backup, or the adaptive immune response. The adaptive immune response is primarily devised of T cells and B cells. It's a secondary defense system that engineers a specific specialized response or antibody or specific T cell to a pathogen. It provides a comprehensive line of defense that eliminates pathogens that evade the innate immune responses or persist despite them. Adaptive immunity, therefore, does what its name implies. It adapts its responses over time to specifically recognize, eliminate, and then remember the offending pathogen. The initial adaptive immune response to a naive pathogen, therefore, takes a little bit of time to be initiated, or around 7 days. During this time, T cells and B cells rev up cells specific to that particular pathogen, where these specific T cells and antibodies are almost like thinking about as gathering a specialized troops or an offensive line in sports. This immune response is unlike innate immunity because, in general, the innate immune response is a one-size-fits-all approach that's based in defense, where the adaptive immune response is a offensive, specific, targeted response. Adaptive immune responses originate after the innate immune cells, the dendritic cells, the neutrophils, and the macrophages break down the pathogens into very tiny pieces called antigens that they present to T cells and B cells. These cells then process the antigens to produce these specific effects. But that is why it takes, on general, 14 to 21 days to get this specific response to defeat the invading pathogen, which you can sometimes you experience it when you have a cold, that generally you feel terrible for about 7 to 14 days, but tend to have a lingering cough or symptoms over about 3 to 4 weeks. But once you have an initial response to a particular pathogen, then you get protective immunity or memory cells that if you ever see that invading organism again, then you have a robust and very quick response to that organism, which is, again, the baseline for vaccines. But why are sepsis risks higher for preterm infants than they are for term infants? To begin with, preterm infants do not benefit from the transplacental transfer of maternal immunoglobulins, which occurs during the 3rd trimester of pregnancy. For late preterm and term infants, these maternal antibodies are typically protective until 3 to 6 months of age. Preterm infants may also have alterations of their microbiome with colonization of more invasive microorganisms. This is especially true for infants that are exposed to antibiotics or who acquire hospital pathogens that tend to be a little more resistant and or virulent. They may also have, they do have very thin, fragile skin, which is a poor barrier against the outside world, but they also have really reduced levels of complements, and that complement will coat bacteria and allow the activation of the complement cascade to where you get antibodies that then surround that organism that allows them to be more readily phagocytosed. They also have reduced levels of chemotaxis, and because they also have delayed adaptive immune responses. These effects are inversely proportional to gestational age. And so the more preterm infants are also likely to need central lines for prolonged parental nutrition, which increases the risk of infection. They might have hypoxia and acidosis that can impede host defense mechanisms or allow organisms to translocate through necrotic tissue. Infants with hyperbilirubinemia can suffer impairment of various immune functions, including neutrophil bactericidal activity, antibody responses, and lymphocyte proliferation and complement functions. And furthermore, brain immaturity may lead to impaired suck-swallow reflexes and the potential for aspiration pneumonia, or to inadvertently place gavage tubes directly into the airway, causing pneumonia. And an immature blood-brain barrier may increase the infant's risk to meningitis. Just a special note about CRP. CRP has a very short half-life of about 19 hours. So the levels should fall rapidly after the elimination of the microbial source. It's produced in the liver, and so infants that have a liver damage, it may not be a reliable source to tell you about infection. Because there's a delay of its upregulation, it usually takes about 24 hours for this substance to be upregulated in infection. It's not reliable for early onset sepsis and should not be checked at birth. That blood volume should just be put into the blood culture bottle so that you get a better and more reliable blood culture result. It may also not increase if you have overwhelming bacterial sepsis where you have granulocytopenia. The sensitivity of this test at the time of illness is only estimated to be 40%, meaning that 60% of subsequently proven sepsis episodes will have a normal initial CRP. So the reason that people get this is it might be helpful in excluding infections in some cases if normal levels are obtained at 24 to 48 hours after the onset of symptoms. I would really appreciate the opportunity to introduce you to neonatal sepsis, and I look forward to the question and answer session.
Thank you very much, Dr. Lawrence, for a comprehensive and informative talk on neonatal sepsis. Our next speaker, we have Dr. Ashraf Karat. She's a staff neonatologist at Mount Sinai Hospital in Toronto, and she's also an assistant professor of pediatrics at the University of Toronto. She has a clinical and academic interest in bridging cardiopulmonary physiology with quality improvement and is undertaking research in neonatal hemodynamics and sepsis and in septic shock. So over to you, Ashraf.
Thank you, Faith. Thank you for inviting me to speak again at the conference this year. And I'm excited to be talking about the hemodynamic derangements that occur in neonatal sepsis. So just to highlight the overview of the big things that we need to think about when managing neonatal sepsis and hemodynamic derangements is early recognition, of course, source control, which is antimicrobial therapy, the identification of the specific hemodynamic phenotype, which we're going to spend some time talking about today, and then goal-directed therapy. So as a review of the great talk that Dr. Lawrence just gave, a reminder that the hemodynamic derangements really start at basically the inflammatory response, and that dictates a lot of what that hemodynamic profile is in neonatal sepsis. So after the invasion of whichever pathogen, viral, bacterial, fungal, into the bloodstream that stimulates an inflammatory response, there's release of several substances that play a role in what that hemodynamic picture look like. In a larger scope, this is a great schematic by Drs. Nguyen and Wong that show really all the underlying processes that are happening at a cellular level that lead essentially at the end to the hemodynamic picture. So after pathogenic invasion, as we just heard, there's stimulation of both the pro and the anti-inflammatory responses, and this leads to several complex processes that occur within the endothelium, causing release of procoagulants, vasoactive substances, and activation of the immune system. What this results in when there is excessive or dysregulated pro-inflammatory response, you can have resultant endothelial activation and then secondary damage, which causes the clinical picture of capillary leak. You can get associated hypotension, hypoxia, and acidosis, and these all precipitate the start of organ dysfunction, which can affect any or all of these organs listed here, and is essentially a precursor state to mortality. So We will focus on clinically on what we can see clinically, which is here on the right side, but it's really a factor of the inflammatory response and the mediators and vasoactive substances that are released. And to us clinically, what we interpret this as is cold versus warm shock. And cold versus warm shock is essentially driven by the relative balance of pro-inflammatory substances versus vasoconstrictive substances that could be catecholamines or other pro-vasoconstrictive release of other molecules. What we know about warm and cold shock, this is really well described in older populations and peds and adults. So we're going to go through this because the general categorization is the same in neonates. So warm shock is essentially a highly vasodilated state. So it's a low systemic vascular resistance state. And as a result, we get the clinical features of warm extremities, normal or flash capillary refill time, bounding pulses, and hypotension. Conversely, cold shock is a systemic vasoconstricted state. So it's a high SVR state. And we get cool extremities, delayed cap refill time, diminished pulses, and a comment that the blood pressure could initially appear as normal because of the excessive vasoconstriction, but eventually could become hypotension related to the secondary findings in cold shock. We'll talk a bit more about that in a second. The preterm infant, from what we know, seems to be predominantly presenting in a warm shock or vasodilated state. That's the predominant hemodynamic phenotype in neonatal sepsis. But kids are very variable and preterms are very variable across the gestational ages. There's a lot of different things that factor in the hemodynamic response to infection. And so some of them are listed here in terms of the various organ systems and how they contribute to the different phenotypes that we can see among preterm infants and the things we need to think about from one baby to another and across the gestational ages. The pathogen can also play a role in the hemodynamic phenotype. So there's only some small studies that basically indicate this, but some pathogens such as GBS can present more like a cold shock picture. E. coli can present more like a warm shock picture. But again, it's really dependent on actually examining the infant. And that's the number one thing is that we can talk about most preterm infants present like this, or most bugs give this picture, but at the end of the day, it all comes down to being at the bedside and assessing that patient in real time. And a note about this is that the phenotype can actually evolve over time, over the sepsis episode. So preterm infants are really good at quickly depleting their own hormone stores, their own neuroendocrine response. And a lot of that is what drives that hemodynamic picture. So sometimes a child can start off in a vasoconstrictive picture and then evolve to vasodilated. So it's really important to examine and re-examine the patient. There's a lot of clinical clues that you actually get from examining the patient. So this is a reflection of the underlying pathophysiology in neonatal sepsis. But though we can't see everything that's on this slide from a clinical perspective, we can certainly pick up on hypoxia, tissue edema, hypotension, even when some of these are late findings. So again, just to reinforce that notion that the exam is the number one piece. So we're going to talk a bit now about a management approach, but we're going to start with the basics, which are the general principles and really the things that kind of guide everything else. And some of these might be simple or intuitive, but it's important to be said. The first thing is to review all vital signs regularly. So we're lucky all of our patients are on monitors and they're on continuous monitors. So we already have a sense of what their baseline status might be. But it's really important to go back and reassess these kids and look at their vital signs and their trends from when the sepsis was diagnosed over the first few days of their sepsis illness. And you can get, again, a lot of subtle clues. As we heard in the previous talk, hypotension is a late finding for sepsis. And there are often a lot of things that will precede hypotension, tachycardia being a really important one. So when you go back and see patients who present with hypotension, often they have changes in their baseline heart rate from 10 to 30 beats per minute. And that can be a sign that hypotension is to come as a compensatory mechanism for the physiological changes in sepsis. The second is looking at the blood pressure measurements. So increasing the frequency. If your unit norm is vitals Q shift, then you have to actively think about increasing the frequency of blood pressure measurements once sepsis has been diagnosed, and look at the pattern of the blood pressure disturbance. So diastolic blood pressure often reflects, or typically reflects, the systemic vascular resistance. So sometimes you'll see the diastolic blood pressure will drop before the systolic will, and that may reflect an evolving low SVR state, versus a drop in systolic blood pressure, which is essentially reflecting cardiac output, might reflect a low cardiac output state. Assess your markers of end organ function. So these are really key because they give you a sense of systemic blood flow and organ perfusion. So look at cap refill time, look in urine output, your neurological status. There's biochemical variables that you can check regularly as additional information for markers of end organ function. And then there's upcoming strategies like using mirrors, which there isn't any solid evidence for use of in preterm infants, but a lot of units are using it as additional pieces of information, and we are at Mount Sinai. Okay, second thing is to look at the sepsis, to understanding the sepsis phenotypes, because this is really the key to understanding the underlying pathophysiology and directing your management. So we're going to go back and we talked about warm shock, which is a low SVR state. That's the primary pathophysiological disturbance. So a low SVR state results in a significant peripheral vasodilation. So you get less systemic venous return and lower right heart preload. As a result, you have low left heart preload, which can impede your left ventricular systolic performance. And then also that could play a role on your right ventricle. Both of these can lead to lower cardiac output and shock. So when you have low SVR state as your primary pathophysiology, there are different approaches to addressing the management for this. Number one, dealing with directly with the low SVR state, so fluids and use of a vasopressor to counteract the low SVR state. And after aggressive fluid therapy and increasing or titrating up your vasopressor therapy, if there is a suspicion of cardiac dysfunction, either through a secondary result of your low SVR state through this pathophysiology, or sometimes we can see direct cardiac impact, direct myocardial injury from the actual pathogen itself, then the child might need inotropy. And this is where targeted neonatal echocardiography can play a role in deciphering whether cardiac function is impeded in the child with sepsis. The opposing pathophysiology is cold shock. So again, a highly vasoconstricted or high SVR state. So your high SVR state can directly impact your left ventricular systolic performance because of an increased afterload state. This can diminish your stroke volume, increasing your end systolic and end diastolic pressures, and then subsequently impeding left ventricular filling, which then further worsens your left ventricular systolic performance. And this goes on until your cardiac output drops and the patient is in shock. So the primary picture that you may see is this high SVR state, which may show you hypertension and the clinical findings that we discussed previously. But because eventually your left ventricular systolic performance is impacted and your cardiac output drops, that's when the patient starts to become hypotensive and there is shock. Management for this patient is a little bit different. So fluids always as first line for sepsis. And the child, because may have, is at high risk for having cardiac dysfunction, may require inotropy for cardiac support. Now I've put vasodilator here and I've put it in lowercase and with an asterisk to remind ourselves that we don't really have a primary vasodilator that we would use in this scenario. And it would be very tricky. We'd have to do it with a great deal of caution. However, there are certain medications that can give you cardiac support and also vasodilation, which could be used, primarily Milrinone, with a giant caveat that if you're going to start such a medication, you have to be really careful that the child's blood pressure is able to sustain initiation of Milrinone, because these kids can quickly go from cold shock, vasoconstriction, high blood pressure to low blood pressure because of cardiac dysfunction very fast. Okay, we're going to talk a bit more about fluid therapy. So there's no real evidence to guide which type of fluid, how much volume of fluid to give. So this is really unit to unit variable. We did an informal survey of Canadian units, and there's some variability between 20 to 40 cc's per kilo that's given. And so most sites are doing something like that. Regardless of which, there's also no evidence to guide which type of fluid. So there's not been any trials in specifically neonatal septic shock, but in critically ill infants, there have been a few trials of looking at colloid versus crystalloid, none of which have showed any significant findings that we could be using in clinical practice. Regardless of how much fluid you give before starting your next step, a couple things. One, increasing the TFI is not fluid resuscitation. So going from a TFI of 140 to 160 is basically providing mils per hour of additional fluid drawn out over an hour at a time. And the second thing is fluid on a pump over 2 hours is not fluid resuscitation. So if you're truly having a child with hemodynamic derangements in the context of sepsis, this child needs fluid resuscitation in the form of fluid boluses that are given quickly and intentionally. On to the next step, which would be the cardiotherapeutics. So there are very little data, unsurprisingly, in terms of the use of therapies for sepsis and septic shock, specifically in preterm infants. But I'm going to present to you the couple trials that there are. This is a trial by Dr. Tourneau and his team that looked at norepinephrine for use in refractory septic shock in kids who have already received fluid or either dopamine and dobutamine. And these are term infants. What we can see here was among all infants, there was a statistically significant increase in mean blood pressure between when the norepinephrine was started and 3 hours later. So what this does, what this information tells us, even though it's a small cohort of infants, is two things. One is that norepinephrine can effectively increase mean arterial pressure in the context of sepsis. And two, the response to norepinephrine as a primary vasopressor is consistent with warm shock physiology. This trial also looked at infants, these are preterm infants now, so this is the only preterm infant septic shock trial that I'm aware of, that randomized children to either epinephrine or dopamine. And this is high dose or alpha dosing epinephrine or dopamine, and looked at outcomes. And when looking in the entire cohort of infants, there was no difference in shock reversal or mortality in kids who were exposed to either epinephrine or dopamine. However, when they divided the cohort into the groups based on gestational age, so greater than 31 and less than 31 weeks, they found that all of the infants who improved in terms of a hemodynamic perspective were in the epinephrine group. So there was a preference for epinephrine response in infants less than 31 weeks. And one of the rationales for this might be the way that dopamine is used in metabolized in preterm infants. Dopamine works directly on dopaminergic receptors to exert its effect, but part of dopamine also gets converted to norepinephrine and then works on catecholamine receptors. And this study showed that sick preterm infants had a diminished capability for converting dopamine to norepinephrine. So they weren't getting that additional benefit of catecholamine receptors. It was really basically getting the dopaminergic response. So that might explain why the really small kids didn't have such a response to dopamine and had a greater hemodynamic response to the use of epinephrine. There are a couple very, very small studies that have looked at additional therapies for managing hemodynamic dysfunction in sepsis. So vasopressin looks like there's potential for use, at least in the context of catecholamine refractory shock, which would be similar to what it's being used for in the pediatric population. And steroids are variably used across centers and across countries. And even when they are used in terms of whether they are first line, second line, or third line therapy, there's of course a physiologic rationale for using steroids in that preterm infants have relative and absolute adrenal insufficiency. They also have quick depletion of their endogenous cortisol. And there is some evidence and at least a physiologic rationale that for kids with capillary leak, hydrocortisone helps to maintain the integrity of that endothelial wall. So there's some reason to use steroids in sepsis, but larger trials are certainly needed. So this is just a reminder that of the various ways that our typical vasopressors and inotrope exert their effect. So again, for warm shock, the primary problem is a low SVR state. So we really want to improve the SVR by giving a predominant vasopressor, which is why dopamine and norepinephrine have tended to be in first line. To help you decide between the two therapies, you have to think about what are the potential adverse effects of giving that therapy. So one example for dopamine would be, as we saw previously, for very small gestational age infants, their ability to potentially convert dopamine to norepinephrine might be impaired. And the second thing is impact on pulmonary vascular resistance. So a lot of kids with sepsis also have alterations in their PVR and are at risk for having acute pulmonary hypertension. So a medication that will also increase PVR, especially in a kid who's already manifesting signs of acute pulmonary hypertension, might not be your number one choice. Similar with the discussion about cold shock and using inotropy in cold shock. So when you think about using an inotrope, think about its secondary consequences, which is why when the child is potentially hypertensive for the excessive vasoconstriction, milrinone might be a good option because it provide some cardiac support and also some reduction of SVR. But if the child's already hypotensive because they now have severe cardiac dysfunction because of their high SVR state, then you can no longer use milrinone because of the impact on SVR, and you might have to use an alternative medication like epinephrine. At our perinatal centers in Toronto, so Mount Sinai and Sunnybrook, we put all of this together in this consensus-based algorithm. And basically, we use this for the management of sepsis and septic shock in our units. Both of our units have agreed to using norepinephrine first line for vasopressor therapy, which is why you see it there. And we also use steroid second line in our units, and vasopressin kind of in the back pocket. Similarly, for cold shock, as we discussed, if you're hypotensive with cold shock, we would use epinephrine. If you have normal or high BP, we would use milrinone. We've provided guidance for basically how often the clinical team should be at the bedside to support, to really be evaluating the patients. But essentially, the basic messaging is examine, 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 and then re-examine and reassess, and put together all the clinical clues that you have, because you don't really need TN echo to get through so much of this algorithm. And you certainly don't need a TN echo to decide which is your first line therapy. It's really deciding if you're in a vasoconstricted or vasodilated state. We have TN echo at both of our sites, so we have included some indications for when to consult or to arrange for an urgent TNE consult. I just wanted to touch on a couple extravascular considerations, because these two organ systems can play a big role in the hemodynamic status. So not for thinking about the child who presents with acute hypoxic respiratory failure and sepsis, which is a common finding. There are cardiac and non-cardiac causes for this. So certainly diminished cardiac output could play a role in hypoxia, but respiratory as well. So often this is a mixed picture where you do have some hemodynamic dysfunction and then respiratory reasons for hypoxic respiratory failure. So two key respiratory conditions to be aware of and to consider for your the child who's severely impacted with severe HRF. Neonatal ARDS, which is an acquired surfactant deficiency, basically relating to destruction of the surfactant biofilm from the inflammatory process. And then you basically get cleavage of the surfactant itself, free-floating free fatty acids, which themselves are pro-inflammatory, and then the cycle sort of continues. So you have a lot of alveolar disruption through surfactant breakdown, and this can cause hypoxic respiratory failure. In addition, think about acute pulmonary hypertension in your child with HRF that doesn't have respiratory illness or problems with ventilation, but has profound oxygenation failure. Some of the pro-inflammatory molecules that we heard about that are released in neonatal sepsis promote pulmonary arterial vasoconstriction. So certainly lay the groundwork for pulmonary hypertension, especially in a kid with baseline lung disease, as all of our patients have, where their PVR state is already abnormally high. So these kids are certainly at risk for acute pulmonary hypertension, and there's potentially a role for TN echo here. Second extracardiac organ system to think about is the kidneys. So the kidneys are very sensitive to fluid balance and sepsis and are high risk for acute kidney injury. So think about, there's two direct impacts really that the kidneys see in sepsis. There's either blood flow impact at the level of the glomerulus. So there's loss of autoregulation of renal blood flow in sepsis and increased vascular resistance. The kidneys, as we probably know anecdotally, are very sensitive to hypotension or altered hemodynamic state, and acute kidney injury can really play a role in the fluid dynamics, which is something you might have to consider when managing the patient with sepsis. You can also see direct tubular impact because of filtration of pro-inflammatory molecules through the glomerulus and actually into the proximal tubule, which again can result in destruction of the renal tubule and can play a role in fluid balance. So kidneys are really, really important in managing the patient with sepsis. And when you have early renal dysfunction, it's a good sign that you have global organ underperfusion. So it's very important to keep a close eye on urine output because the kidneys are so sensitive. Once they get impacted, it's a really big sign to act fast to restore hemodynamics to prevent further deterioration of the child. So just a few things to summarize. So direct consequences of sepsis or the inflammatory cascade are really what's responsible for the variable hemodynamic infant phenotype in the preterm infant. And we can use warm versus cold shock as a way to classify the patient. And this is really what directs your management once you've decided which side the patient falls on. And then I'll add reassess your patient. And of course, we need a lot more trials and prospective studies to kind of fill in our knowledge gaps. Thanks.
Thank you, Ashraf. That was fantastic. And it generated a lot of questions. So I'm sure we're going to have a great Q&A session later on. Our next speaker is my pleasure to introduce Professor Kurt de Wal. He is a consultant in the John Hunter Children's Hospital in Newcastle in Australia. It is very early in Australia, so thank you, Kurt, for being here with us today at this early hours. Dr. de Wal completed a PhD in central blood flow measurements at the University of Amsterdam, and his research interests are in neonatal hemodynamics and novel ultrasound techniques. Thank you, Kurt.
Thank you, and thanks for inviting me, and thanks for the previous two talks about setting the stage. And I was asked to talk about the use of echocardiography in sepsis, and we got 20 minutes, so I'm going to briefly sort of go to the overview of how, for instance, I would use and how you can use ultrasound in sepsis. I think there are three particular things which I want to highlight in this presentation, which is phenotyping sepsis, targeting treatments, and I will talk about some emerging new concepts. So Shelley already talked about the definition, that we don't have a definition, but the two key factors which are in the sepsis 3 definition, I think are still very applicable even to our newborn population. That sepsis is a life-threatening organ dysfunction with a dysregulated host response, and that septic shock then adds underlying circulatory and metabolic abnormalities that increase mortality. And if you ask about what increases mortality in newborns by sepsis, then there is a couple of ways to help you phenotype or get some ideas about this. We already talked and presented about the NSOFA score, which uses hypotension or the treatment of hypotension, platelets, and respiratory support as important factors. But I'm going to talk about how then you can also use cardiac ultrasound to help you phenotype sepsis. And it's important to then establish a degree of left ventricular cardiac dysfunction, either systolic or diastolic, and look for the presence of pulmonary hypertension and right ventricular function. So this is data from adults, and you see cardiac dysfunction on the left, the ultrasound measurements in the middle, and surprisingly high incidence. This is, of course, cardiac sort of adult patients who end up in the intensive care. But on the right, you see the effect on mortality, the hazard ratio. So that means that if you try to phenotype sepsis, that these parameters can certainly I think help you to come from, sepsis to septic shock. And we'll go through a couple of these ultrasound parameters. So this is the heart, this is the left ventricle, and a lot of important stuff happens in the left ventricle with sepsis. It's the interaction between the left ventricle and the arteries, and it's base to apex movement. So if you want to assess cardiac function, then this is probably my favorite. This would be my favorite. I use tissue Doppler velocities, the base to apex motion, to give me information about systolic function, which you can see at the S prime, which is either preserved or lower in sepsis and septic shock. But you also get some information about post-systolic motion and dyssynchrony between the left and the right ventricle or within the ventricle itself. And it adds diastolic information, which I think is quite important in sepsis. You can go even further. You use speckle tracking. I think it's still pretty difficult to use this in a sepsis setting, but I do agree with this statement and this particular study that speckle tracking analysis or tissue Doppler are much more discriminative in finding the differences between subclinical or even clinical difference in cardiac dysfunction in sepsis or other diseases with cardiac abnormalities. So systolic dysfunction, I think it's less likely if you work in the NICU, particularly, it's less likely in the initial phase of newborn sepsis, but as Rav has explained, it can change quite rapidly. I do think if it comes to ultrasound, radial measures are not so able to discriminate subclinical left ventricular systolic dysfunctions, but there is very limited data in septic newborns. Going to diastolic dysfunctions of the left ventricular, which is impairment on some or all of the components of diastolic function, which includes relaxation, recoil forces, stiffness of the ventricle, and left atrium function. And that results then in an increased left ventricular and diastolic pressure or a raised left atrium pressure. That by itself has a clinical consequences because the backward pressures will give you then respiratory signs and symptoms and can aggravate the acute respiratory distress syndrome. How do we look at that? There's two particular ways to looking at. You can use it with pulse wave Doppler, looking at the S wave on the left and the E and the A waves, the early diastolic and late diastolic waves on the right. But if you superimpose tissue Doppler over that, you get this wonderful information and combined information where you can take a set of measurements which can tell you something about relaxation, which sort of starts at the beginning of dystole, actually starting what we call systole, and moves over till the peak of the E wave. You're going to get information and measurements which take place at where most of the recoil is taking place, or where the stiffness is taking place, or specific measurements for atrium function. And with a combination of these things, or a multi-parameter approach where you take parameters which sort of reflect any of these stages, you can then assess if there is a high likelihood of an ultrasound diagnosis of diastolic dysfunction. And really apply this to different populations, but also to preterm babies with early onset sepsis and with late onset sepsis. And we found that at least 1 in 3 of babies who had an ultrasound, and I think is a selected population, these were not prospective studies, had diastolic dysfunction with septic shock. These are the parameters which can be used to assess pulmonary hypertension and right ventricular function, and I'm not going to go into detail. I'm just going to refer to the papers by Amish or Willem, which have all the details of how to assess this. But I'm going to pick out one. It was actually discussed on the Monday or Tuesday session. When we assess pulmonary hypertension in preterm infants, they often have the ductus arteriosus, so you can look at the ductus arteriosus flow pattern to determine if there's pulmonary hypertension. Here, schematically presented, pulmonary hypertension with the pulmonary pressure in blue and the aortic pressure in red, so that gives an orange ductal flow velocity, which is a bidirectional shunt. And if you then have severe pulmonary hypertension with a raised pulmonary pressure, you get a much larger right to left component, which goes downwards. However, look at this one. This is systemic hypotension, and that will give exactly the same flow pattern on the ductus arteriosus. So it is really important to document systolic blood pressure during your ultrasounds if you want to use or assess ductal flow to determine if there is pulmonary hypertension. So this is about the assessments, that there are different parameters you can use and get yourself sort of familiarized with. But what can we do then to target treatments? And the treatments we're going to talk about is, the choice of a vasopressor versus an inotrope. And as I've talked about that already before, I'm going to talk a little bit more about fluid treatment and one slide on how you can target treatments for sepsis with pulmonary hypertension. So the blood flow measures RVO, SVC flow, LVO. Be mindful of the presence of shunts, but if there is a high blood flow, warm shock, high cardiac output, low SVR, then the choice would be a vasopressor. And this is probably the most common situation with presentation of sepsis if you work in a NICU, where all the patients are in hospital and usually develop their sepsis in hospital. However, if you work in a PICU or an ED, or you get patients coming from outside back into your unit, about half of them are more likely to have cold shock with a very low cardiac output. And in that particular or a situation, an inotrope might be better. And as we've already explained, you can have variations between how you start. Usually the physiology will be warm shock to start and then becomes cold shock, and then you can vary between the two. Fluid therapy has been mentioned in the previous talks as well, but what we know from all the literature, that there are strong and consistent negative associations between fluid overload and adverse clinical outcomes in either pediatric and adult sepsis. So we need a novel approach to fluid therapy. And I think the Adult Society, Intensive Care Society is much more advanced in this and have already developed some novel approaches, which I'm going to highlight. Let's try and understand this sort of system where we talk about fluid to increase preload and increase central venous pressure, then this is sort of the physiology, how we understand it. This venous system is this big vessel which has a mean circulatory filling pressure. It is filled by the arterial system and then sort of ends up towards the right atrium where it creates central venous pressure. But it's a bit more complex than that. And actually that vessel has an opening tube which can be manipulated usually by the neurogenics or the autonomic nervous system up and down very quickly, or some more chronic measurements to the RAS system. But it also means that this vessel is actually into two components. You have the top bit, which is pressure generating and helps create that central venous pressure. But that other bit is actually unstressed volume. It is not pressure generating and can be recruited at times when it's needed. If we then look at what is normal and what is, for instance, acute hypovolemia and hemorrhage and acute bleeding, where you have to quickly recruit that unstressed volume to maintain your central venous pressure, then this is sepsis. It's a relative hypovolemia with venodilatation. So the amount of volume into the system is probably still the same, certainly in the early phases of sepsis. But how many is recruited and how much pressure is then generated will be different from patient to patient. So will a newborn with relative hypovolemia benefit from extra fluid? Because on one end, the fluid can end up as stress volume, as stroke volume, which is great, and then it's fluid responsive. But on the other end, if fluid ends up as extravascular lung water or edema, then you're not fluid responsive, and actually fluid has created harm. So you can try to test this and measure this, and the adult call this the mini fluid challenge. And it's based on the Frank-Starling curve, which you see here. Preload on the x-axis and stroke volume on the y-axis. And if you're on the sort of the left side of that curve already, and you give a fluid bolus, you look at what the stroke volume was before, then after the fluid bolus, your stroke volume would have significantly gone up. However, if you're on the right end already of that particular curve, you give then a fluid bolus, then what would happen, of course, is that the stroke volume will barely change. So this is called the mini fluid challenge. And this is an example in one of our preterm infants who had late onset sepsis, where you use an apical view and you manipulate your ultrasound to have the least angle of inclination, and you change your sweep speed. And then you measure all these different variations, as you can see here, the peak velocities of the left ventricular output before the fluid bolus. Then you give a fast fluid bolus, as Carrot said, if you want to do something about your vascular distension of these vessels, you need to give it fast. So this is 3 milliliters over 5 minutes per kilogram, and then you look at the changes. So you just stand by the bedside. It's a bedside test which takes 5 minutes, and you can see those changes, and the change in peak velocity is over a certain point. And in the adults and the pediatrics literature, they use 15%. We need way more research on this dynamic fluid responsiveness test, or the mini fluid test in newborns. There's lots of questions about what is the bolus volume, the infusion time, what ultrasound parameters, should it be LVO or should it be something different, and is that cut point of 15% correct? And so I hope I can recruit all of you to join in this particular type of research. What is also important to realize, though, if you're fluid responsive, that doesn't necessarily mean that you should just have more and more fluids. The clinical context is really important. You need to look at the degree of cardiac failure, maybe sort of, correct that first before you start giving more fluids. And for instance, what was also mentioned is if there's significant renal failure, just giving more fluids will actually also not be beneficial. One slide about pulmonary hypertension and how you can use help with ultrasound to septic shock if you want to target the treatment in pulmonary hypertension. Pulmonary hypertension is increasing pressure, and then here are the physiological determinants: flow, resistance, and left atrium pressure. And if left atrium pressure is one of the reasons why the pulmonary pressure is high, or left ventricular dysfunction leading to increased left atrium pressure, then your treatment should be, of course, inotropes or inodilators to support that, sometimes even diuretics. However, if blood flow is one of the main contributors to increased pulmonary pressures, and we had a little bit of a discussion about that on the Monday or the Tuesday sessions, but we're not quite sure. But I think using mechanical ventilation can certainly curtail pulmonary blood flow, not to extreme extents, but to some extent. And if your resistance is high, which is actually quite unlikely in late onset sepsis in NICU patients, then nitric oxide can work. And a Canadian group has shown that if you use nitric oxide in late onset sepsis in hospital pulmonary hypertension or hypoxia with sepsis, none of them will respond because it's just not part of their physiology or pathophysiology or phenotype what created the pulmonary hypertension. The last couple of slides about emerging new concepts. We know that sepsis pathophysiology starts with vasodilatation, reduced afterload, and progressive cardiac dysfunction if not supported. The interactions between the heart and the arterial system, the vascular-arterial connections, are actually not easy to differentiate with the current ultrasound parameters. I know I've shown you tissue Doppler, but tissue Doppler is very dependent on preload and afterload. Speckle tracking might be a little bit less dependent, but even then, they're still dependent on what happens between those two situations. So there is this new concept which has been mentioned in targeting treatment in septic shock by the Adult Society, which is called ventricular-arterial coupling, or VAC. To explain this, you best look at a pressure volume curve of a heart. And this is the volume on the x-axis and pressure on the y-axis. And we know from a cardiac cycle, when it fills up, and then slowly at the end of the filling, sort of the pressure goes up a bit more steeply. Then there's the isovolumetric contraction time, and then you get your ejection, which goes to your end systolic sort of pressure. And then you get your isovolumetric relaxation time. And out of these pressure volume curves, we have a couple of things we can measure. We know the stroke volume is from the end systolic volume to the end diastolic volume. We know that everything under the curve is called stroke work or myocardial work. Myocardial work is slightly different, but stroke work. There is an end diastolic pressure volume relationship, which is preload. And there is an end systolic pressure volume relationship, which is afterload. And we know that if there is true hypovolemia, or sometimes also in sepsis, you can have a reduced preload, and it would look a little bit like this. And we talked about if you then give fluid and it responds, you get back to that increased stroke volume, then this is called fluid responsive. Or if you give too much fluid, we talked about it, then you get fluid overload, which has to be maintained and has to be able to be pushed to that heart in every single beat. If you go to this baseline situation where we have ESV in the bottom and EDV at one end and ESP is end systolic pressure, then we know that the change in volume and the change in pressure from EDV back to ESP is actually called the arterial elastance, the end systolic pressure divided by the stroke volume. That's a certain set of volume and the amount of pressure changes which take place. And there's also ventricular elastance more related to the heart, which is the end systolic pressure divided by the end systolic volume, going to an arbitrary measure called V0. So these relationships and these angles between these two lines can change from beat to beat. They can change with treatments. And the relationship between these two is called ventricular-arterial coupling. And if you look at these particular sort of definitions, what's in there, then you can see that there's a couple of parameters in there which are interesting. End systolic pressure, which is a little bit hard to estimate in newborns, but there is a sort of formula. But what I find important and how I sort of started to appreciate end systolic volume more and more in situations like particularly sepsis. And this is a study by Grantino is a great study, which I would highly recommend to read, to how they then manipulated these lines and kept on measuring these lines in a very strict way in a large cohort of adults with sepsis. And you could see sort of the changes in either afterload or in the contractility and the stroke work or the left ventricular efficiency, myocardial work, with each step they take. And this gives us a better understanding and better possibility to target your treatments to what you think that particular patient might require to get back into, organ perfusion and return of circulation, which is efficient during sepsis. So I will summarize with a couple of slides how I use ultrasound. I use it to phenotype sepsis and hopefully establish a mortality risk. I use longitudinal-based apex measures for left ventricular systolic function. I always explore diastolic dysfunctions, as it is, I think, a really important measure related to mortality in our preterm infants. And I look for pulmonary hypertension, whether or not there is right ventricular dysfunction. Then, as Karat described, I use central blood flows to choose either a vasopressor or an inotrope, and I keep on measuring and following these babies if they remain in shock to maintain and follow if changes occur. Explore the early determinants of increased pulmonary pressure to also target treatment if there is hypoxia with pulmonary hypertension, usually acute pulmonary hypertension with sepsis. And I briefly described here the ultrasound parameters to prevent fluid overload. That's what the mini fluids challenge can do. And I described and detailed ventricular arterial coupler as an emerging new concept to target cardiovascular support. Thank you, and we have the questions later.
Thank you so much, Professor Duval. I mean, that was wonderful, and I'm sure it's generating a lot of questions in everyone's mind. And I'm really pleased to introduce our next speaker, who is Dr. Danielle Rios. She is an associate professor of pediatrics in the division of neonatology at the University of Iowa. Her area of academic focus are the hemodynamics of critically ill neonates and predictive analytics to improve outcomes of extremely low birth weight in infants. So yeah, over to you, Dr. Rios.
Thank you so much. Sorry, let me get my slides going. Are you seeing wrong? Okay, can you see my slides?
Yes, we can.
Okay, great. So, so thanks so much for allowing me to discuss this topic. I will be talking about artificial intelligence in general, and then mentioning a couple of the current algorithms that are out there for use in, like our clinical times and how they relate to sepsis. I don't have any disclosures, but I am going to be talking about multiple devices and products that are either FDA approved or some of them are just FDA cleared. So just in talking about artificial intelligence in general, essentially what that means is that you're imparting kind of data, information, and abilities to a machine, essentially to a computer. And so one of the most common, I guess, instances of artificial intelligence is developed by Amazon. So you have Amazon Echo or Alexa services, essentially. So you have a user who's over here and they ask Alexa something. So, hey, Alexa, what's the temperature in Chicago? So the device actually has to send that voice into kind of the cloud where it's converted into commands, and then it's processed by some type of supercomputer essentially in the cloud. Then the output that is going to go back to the user has to be changed into a voice output, which is then given to the user through the Amazon Echo device or whatever device that you have Alexa on. And the answer comes out and it says the current temperature in Chicago is 6 degrees Fahrenheit. So when we're thinking of artificial intelligence, this is what we do. My Alexa is actually just talking right now. I'm sorry if you hear that. So the general idea of artificial intelligence or AI is that you'll have past data. You have to learn from that past data. And so depending on what type of process that you're actually going to be using with your artificial intelligence, it'll change how you learn from that data. But then you put that into kind of a model or whatever it may be. Again, there's multiple different types of artificial intelligence that then predicts the output so that you have that but all kind of types of AI really have this general model. So the two that I'm going to talk about are two types of machine learning. AI and deep learning algorithms is actually one subset of machine learning. You have kind of this input layer, you have a hidden layer, and then you have an output layer. So when we're talking about just the generalities, this is kind of your past data. So you've put a ton of images of retinas into this, this algorithm. Then you have this neural network where you need to train. So this is your input of your data. And then kind of the actual meat of the process is being done here. So that later on, when you actually put in a new input, which is a new image of a retina that you want to know matches your algorithm or not, that will go back to your neural network, the hidden layer, and then it'll spit out whether that's a diseased or healthy eye. And so this is how we are using a lot of artificial intelligence in the clinical realm at the moment, because it's easier for radiology, imaging modalities as well. So the machine learning algorithms are kind of what I'm more used to, what we talk about in wanting to be able to do some predictive analytics. So what does that entail? It's a very exhaustive process where you have to have a lot of data and you have to train your model very well. So these are the 7 processes that are required in order to kind of have an adequate machine learning algorithm. So you gather your data, whatever data that may be. For us, for instance, it's vital sign monitoring. Then you do your pre-processing, making sure that your data is actually what you wanted and expected to be. You have to choose the model that you think is going to give you the output that you are looking for. And there's multiple ways to do that. And this is beyond the scope of this talk. Once you know that the model that you want to use, or that's going to be best for what you're trying to do, you have to train that model, go ahead and test that model. So the training and the testing is usually done with the same kind of data. So you use 80% or whatever of the data to train it, and then 20% to test it to make sure that you're actually looking at what you want to look at or what you think you're looking at. Tuning the model is what I would consider validating. So then you get new data and make sure that it actually does validate and do what you want it to do. And after you've done all of that, if it actually is working as expected, then you can start doing some prediction. So predictive analytics is kind of what we hear. Okay, so then just a quick what's required in order to be able to do this. Well, as I was discussing, you have to get your data. So how are you going to get that data in a robust manner? So essentially, you have to collect continuous in our sense, in what we're doing in the NICU, collect continuous vital signs and other monitoring modalities and store that data in a very accessible manner so that you can go back and actually utilize that data. Multiple companies have platforms or software programs that will allow you to do this. One of them is Ediometry, which is shown right here, that I believe some of you, your institutions are using. Those that have Philips monitors can use Philips Data Warehouse that actually has kind of that ability to collect and store those data as well. So at University of Iowa, where in my previous institution, we use SickBay, so this is what I'm more familiar with. But ultimately, even though I'm discussing kind of how we do it with SickBay, this can be done with any other platform, and there's many other ones other than the few that I mentioned. So what you do is you get your clinical data. So information from your bedside monitors, your ventilators, other devices. So you may have mirrors, non-invasive cardiac output monitoring, et cetera, your labs, your medication schedules, your EMR, all of those things. And then you store them and collect them in one central place, which is the actual platform. And then you decide how you want to see it and utilize that data. So some of the ways that we use this data, in the times of COVID, a lot of institutions have turned to virtual monitoring, so real-time virtual monitoring, having kind of a virtual ICU. So this would be moving if it were in real time. So you can actually see the patient's monitor, not at the bedside. So maybe in your office, or maybe you have COVID, and so you're not able to go into the office, and so you can monitor from an outside area as well. This is just one patient, but you can actually monitor all of the patients in the hospital if you wanted to. And some of the adult institutions have some validated risk scores. And so one person can have kind of a centralized area where they're looking at 100 patients, say, and because they have the different risk scores that are integrated into the platform, they can alert people that are actually at the bedside to those that are having kind of higher level risk scores. Another way that we can use that platform is from historical timestamped monitoring. So essentially, you just collect all of the data and then make sure that it syncs with all of the rest of the vital signs. So this is just a screenshot of a patient who was on one of my research studies where we were looking at ST segment changes, NIRS, non-invasive cardiac output monitoring, and blood pressure. Additionally, you would have your ventilator data, your just regular heart rate data, your heart rate variability, et cetera. But this was kind of the stuff that I was focusing on to make sure that we were actually getting that data. And so you can see that right now we're looking at 15 seconds. So you can look at 2 seconds or at 2 weeks or 2 months and have that data so that when you have an event, you can actually analyze that. So the difference in all the different platforms is really resolution. So are you going to have your waveforms? Like, do you have the ability to do that? And then are you going to be able to tell when something happens? So say at 9:54, 29 seconds, there was an event, then you want to know that you can actually see all of the different vital sign changes that happened at that event. Another way that some institutions use this is for like root cause analysis and quality improvement. So if there's adverse events that have happened, you can actually go back in time and see at a different granularity what exactly transpired. So again, this is looking at 4 hours, 3.5 hours. But if you really wanted to know what happened in this 15-minute time frame where the patient deteriorated, you could look at that with increased granularity in the seconds or minutes. So let's get into some prediction models to detect sepsis then. I'm going to talk about 2 that we have. One has already been mentioned, but that we have that some are using in order to evaluate sepsis. But before we get into that, I want to talk about kind of the prototype algorithm. So like what is going to be the most beneficial. So this is a screenshot of the virtual monitor that was utilized during a research project, a study at Texas Children's Hospital, where they were looking at single ventricle physiology patients, so hypoplastic left heart syndrome or other kind of single ventricle patients. And what you can see here is that this was your risk index. And so this is the predictive algorithm, essentially, that's kind of just going on in the background, where you have all of your vital signs. They have 5 lead, if not 12 lead EKGs, and so they can look at ST segment changes and heart rate variability and all of those things. So they may have NIRS, they will have other monitoring modalities. So you can kind of collect all the data from those and then allow it to go into your algorithm. And so this algorithm in particular was able to predict up to 6 hours prior to a cardiac arrest, the increased risk of that patient having that arrest. And additionally, it gets sent off to this institution uses Volt phones. So it actually gets sent to the primary user, to the primary care team as a message from that platform. And so this is kind of like, in my mind, what type of algorithm we need, something that gives us lead time for us to actually go in and make a change prior to that patient actually having that problem. So what's our problem? Our problem would be sepsis. So the goal of predictive monitoring in this sense would be to get into this red area where you do have some signs and symptoms of infection, but before they're actually clinically realized, knowing that the patient is changing, that their physiology has changed, that their vital signs have changed. And so in this time period is when we would be able to do the predictive monitoring to then perhaps initiate antibiotics or pressors or volume or whatever it may be in order to help that patient with their prior to the clinical diagnosis of sepsis or maybe necrotising and colitis. Those are the kind of the two that are looked at. So we've been talking about clinical sepsis and how the cytokines get released and it's a multi-organ involvement and all of those things. You can have warm shock, you can have cold shock. And I think the one thing I want to focus on is the fact that in neonatal sepsis, as has been said before, it's kind of non-specific signs and symptoms that you're seeing. So you may have apnea, you'll have some of the patients will have bradycardia, but some of them will have tachycardia, you'll have desaturation, a change in your activity levels. Some of them will have lethargy. So some will have symptoms that it's more likely that you'll catch early on, and others will have very non-specific and vague symptoms. And so having a predictive algorithm is going to be very beneficial in those patients. So talking about the HERO score, so the heart rate characteristics index is what this is really looking at. And so here in this figure of A, this is kind of the normal distribution of a patient's heart rate in the neonatal ICU. So they'll have a lot of different small accelerations in their heart rate. And then on the flip side, a lot of different decelerations as well. So decelerations here on the left and accelerations here on the right. So it's a very bell-shaped curve. So it's normally distributed where they have just as many accelerations as decelerations. But in a patient who actually has sepsis or necrotizing enterocolitis, what you see is you don't have the accelerations that you usually have. What you do have is more frequent and deeper deceleration. So you can see the skew of the curve now to where it's mostly decelerations and very few or no accelerations. So in one of the larger studies that was done with the HERO score and looking at its predictive abilities, this is kind of the monitor that you would see, and this is kind of the changing of the score in relation to the patient's vital signs or heart rate variability. So easy to look at just kind of a clinical example is patient on the left doesn't have sepsis, patient on the right has sepsis. You look at the heart rate, you can see you have accelerations and decelerations here, mostly just bigger decelerations. And then looking at your desaturations, you have kind of more variable saturations here and further larger desaturations. And this patient didn't have sepsis, whereas the one on the right did. So talking about the randomized control trial that, or clinical trial that I already alluded to. So this was using the HERO score, so 9 level 4 in ICUs with over 3,000 babies. They were all VLBWs. And so what happened is they all had the HERO score monitoring. However, half of them had the score displayed to the clinical team and half of them were masked. What they found was that they reduced mortality by about 20%, from 10.2% to 8.1%. And you could even see that benefit in the less than 1,000 grams. They were originally just looking at the LBWs. And I believe that they needed a smaller number needed to monitor in ELBWs than the VLBWs. The one thing that they did see was that, of course, with the HERO score being displayed, these patients had more often workups, so blood cultures and labs drawn for suspicion of sepsis. To be expected, I think. The other score that I wanted to just briefly discuss is the NSOFA score, so the neonatal sequential organ failure assessment. This is drawn from adult literature, and so it's kind of trying to be modified for neonatal sepsis. but you can see it's the respiratory, cardiovascular, and hematologic score. And so the respiratory is, are you intubated, are you not intubated? And essentially, what are your stats and how much FiO2 are you requiring? Whereas your cardiovascular score, well, we have heard from other people earlier in the session talking about all the different things that we should be looking at. This really looks at, are you on an inotrope, and do you require steroids? And hematologic score is just your platelet count. But you can see that as your end-surface score does increase, your risk of mortality increases dramatically as well. So at University of Iowa, which is where we practice, we actually do have the end-surface score kind of readily available for us to evaluate on our patient list. And so you can see green is a low score, yellow is an intermediate, and red is a higher score. And once you get above 8, your risk of mortality does increase. So looking at these two scores for mortality. So here on the left is the HERO score, on the right is the end-surface score. So you can see this, the HERO score does increase in patients. These are the survivors of sepsis, late onset sepsis or NEC, and these are those who died. So from the time of the blood culture to about 24 hours after the blood culture, the HERO score is more significant, or is significant in predicting mortality. Whereas the end-surface score at all of these time points, if you're looking just at mortality, it was kind of more accurate at predicting the mortality, where it was higher at all these different time points. When it's looking at just sepsis, so late onset sepsis and NEC would be this dark line. So the HERO score, again, in multiple different time points, is good, does increase in patients with late onset sepsis or NEC. But you can see here, when you just have like a sepsis-like illness or a rule-out sepsis, it's not very good at distinguishing between those two. The end-surface score, similar case where if you have sepsis or NEC, the score is going to be elevated compared to those that just have rule-out sepsis. But again, when you have just sepsis-like illnesses, it's not as good at distinguishing between that and the rule-out sepsis. So another just clinical example, and this is just a reminder of normal and abnormal heart rate characteristics. So this is a patient who then did develop late onset GBS sepsis. And I think it's just very telling when you look at the continuous vital sign monitoring that there is a distinct change where you have these larger, more frequent decelerations once the patient has clinical sepsis. But not all changes in heart rate are sepsis. So again, you have this patient who again has no accelerations and just these deep decelerations. However, you see, because we're looking at it continuously, that there's this very big jump up, and this is actually SVT, though it does have that same characteristic of the sepsis, sepsis kind of variability. It's not sepsis. So what are the shortcomings of the current algorithms that we have available to us? Well, the HERO score, it focuses on heart rate variability, which is very helpful. However, there's so many more things. There's so much more vital signs. There's so many other monitoring modalities that people are actually putting on their patients at this point that I'm sure there's more that can be evaluated as well. All of us can agree that a 22-weeker is very different than a 40-weeker, and their heart rate characteristics are going to be different as well. So we want something that's going to be generalizable to all the populations, not just kind of one subset. And then we have to think about healthcare costs and the possibility for unnecessary workups and unnecessary exposure to antibiotics. However, with the improvement in outcomes in the future, if you do catch this, if you are able to predict it early, I'm sure all of us would say makes up for that. And the end-surface score, this unfortunately is more of a clinician-initiated data. So there's not going to be any early warning. So if you're intubating a baby and adding inotropes and checking blood culture on CBC and looking at platelets, you're already worried about this patient. So it confirms your suspicions. This isn't something that's going to be working in the background to alert you to that patient. I think all of us know if you're on 6 pressors and your platelets are 5, that you're at a high risk of mortality. However, there are, again, still other lab values. There's other vital signs. There's other monitoring modalities that aren't integrated into this score. It's a very simple score that is good at predicting mortality. However, there may be more that could be added to that. So in conclusion, I think all of us know that sepsis is a very important clinical entity, and we're all concerned about it, and we want to prevent it in our patients. So does artificial intelligence have the potential for helping us do this? Absolutely, it does. But currently, we don't have one, algorithm that would work for everybody and be generalizable to all institutions. So we do need to work on that. I think everybody's kind of mentioned that. There's more work that needs to be done in this area to give us that ability. And one of the things that we want to make sure that we do is minimize the false positive, right? Because sepsis is rare. There's going to be some false positives, but minimizing that would be helpful if we could have an algorithm that would do that. And just a quick plug in that, if you're at an institution that doesn't actually have kind of a software platform in order to do continuous vital sign monitoring, you really do want to consider exactly what you want to get out of it prior to spending any costs that would need to be needed to actually implement it, because the different platforms do have different abilities. And so, so we would ideally come up with some type of algorithm where all of the different platforms would use it, but just something to keep in mind. Thank you so much.
Thank you